So I'm going to be talking about work that I've carried out alongside Mood and Chantel and others based at the SMS and elsewhere about labour rights issues in healthcare supply chains. It's often an issue that people don't know very much about, so I'm going to give a brief introduction. You may have seen this article in The Guardian a couple of years ago about the NHS PPE being sourced from companies repeatedly accused of forced labour. And essentially we have a couple of really good case studies of products that are produced using forced labour with unsafe working conditions, and as you can see in the photo on this side from a report in the last 15 years, of using child labour, and this is in the production of steel surgical instruments, and we know that about two-thirds of the world's steel surgical instruments were produced in this area. So this is obviously something that's of huge concern to us. We can't be treating the health of one population while we're harming the health of another population elsewhere, and it's really about recognising that even though we're focused on how do we improve the health of our local region, that actually our healthcare systems are internationally connected, and this is something that's really important for us to take responsibility for. So as I said, we have these case studies, but what actually is the scale of this problem? And that's what we don't know. So that's where this research is based. So we wanted to ask the question, what is the risk of labour rights abuses within medical supply chains? In order to address that, we wanted to identify some data sources on product country of origin, and I'll explain why we're using that in a moment. And we wanted to utilise that data to identify the risk of products supplied to high-income countries. And we wanted to estimate and compare the risk for medical products at an overall level and see if we can identify some high-risk products. So as I said, we're using data on country of origin. The reason for that is because we don't have granular data on the actual on-the-ground labour rights abuse incidents, but we know that country of origin is predictive of the risk of labour rights abuses. So we utilise the International Trade Union Confederation's Global Rights Index, which brings together some on-the-ground reports of incidents of forced labour, as well as looking at the legal and policy aspects for those particular countries. So as you can see, they produce a report every year which gives a risk of the different countries, and this is the scale that we use to assess that risk. So going from sporadic violation of rights up to no guarantee of rights due to breakdown of the law. And we got a primary data set from Norway for that year in 2015-2016. The data from Norway had over 23,000 items within it. And the shocking thing, first of all, you can see is even though the country of origin was mandated, still 43% of those products by value did not have any information on country of origin. When we look at the products by value that we do have data for, 49% of those by value came from countries that we would consider to be the highest risk of labour rights abuses, so countries that have systematic violations of rights or worse than that. Comparing that with the audit carried out in Cambridge, that looked at 100 items of the highest spend at Addenbrooke's Hospital, and 26% of country of origin data was missing, but of those that were available, 60% by value were coming from those highest risk areas. So this is something that's obviously of huge concern. Our project is a completely new scale of study. We've not done any previous work that's looking at what the risk is in the medical products industry, even though we know that other industries like electronics and the textiles industries have really high levels of research activity in trying to identify risk and combat that. We've identified that medical products are likely very high risk of labour rights abuses. And we've also utilised that country of origin methodology, and that's something that can be used locally, particularly by procurement professionals to look at their own supply chains and consider where they might have risk areas. And there's so much opportunity for future research here. We need to understand more about the risk at a granular level for specific products, and we do have some products which we can identify as more high risk, but still there's a lot of work to be done on that. And we need to understand what factors in our healthcare systems influence that risk and how can we reduce the risk. And there's so much work for local and international collaboration as well, looking at policy, but also utilising the knowledge of other researchers in sort of supply chain management, utilising those that we have here that work in procurement. So lots of interdisciplinary work that can be done. And obviously this also has direct overlap with the environmental sustainability agenda as well, particularly with circular economy work. And as Chantal has outlined, we're still going to have some linear components to our supply chains, and we really need to make sure that we are responsible with those. So thank you very much everyone for your time listening today.